My name is Ben Kozyak. I'm a cardiac ICU doc at the Children's Hospital of Philadelphia, and I'm going to be talking about how to use ultrasound for the placement and rescue of umbilical venous catheters. I don't have any disclosures, and just to start off, I'm going to talk about why umbilical venous catheters are great. I think many of you guys probably share this opinion, particularly in preemies and cardiac neonates, and in hospitals where PICs aren't readily available. UVCs are kind of the go-to central access for our critically ill newborns. And unfortunately, though, they have a pretty high failure rate, on the order of like 30 to 50%, which is a problem when you're relying on this form of access to give your patients inotropic support, parenteral nutrition, large volumes of blood products after cardiac surgery, et cetera. And so we developed a point of care ultrasound technique to address some of these problems and increase the rate of successful central UVC placement. This was sort of born out of necessity. I don't know how some of y'all's hospitals practice within the cardiac center, but ours has something of an allergy to percutaneous central access, particularly in the single ventricle babies. And so often the kids will come out, if they don't go in with a central UV to the operating room, they come out with an intracardiac, a couple of intracardiac lines, and peripheral access, but that's it. And so, and as you guys know, a lot of these kids need more central access than that for the early management. And that's something we debate frequently about when it comes to risks and benefits and so on. But there's a premium on having a good UV in our center. And so we sought out to see whether we could improve our success rate with ultrasound. And it turns out we can. You've all seen these radiographs before. Umbilical venous catheter is, right up here in the midline, and here coursing off into the right portal vein, here coursing off into the left portal vein. This is unfortunately a common problem, as I said, affecting like 25 to 50% of UVs, even placed by really experienced neonatologists. And that's pretty consistent across multiple reports in the literature from different types of centers and in different parts of the world. I think we've all probably been there, you're pushing the catheter in and out, kind of blindly feeding around, pushing on the liver, moving the baby around, trying to line over line, et cetera, but then it still doesn't go in. You really don't know what it is that you're doing, why it works sometimes, why it doesn't work other times, and it's a super frustrating experience. And you probably eventually curse in front of a baby, which you shouldn't probably do, and then give up, leave it low, and and move on. Given the fact, though, that having a central UV is can really make a difference for the management of our patients and spare them other forms of central access that they might otherwise not need, and vessels that they might otherwise need for things like cardiac catheterization and ECMO. We developed this process for resiting these lines or successfully placing these lines with ultrasound. And what I have on the screen now is a set of illustrations overlaid on radiographs to illustrate how an umbilical catheter gets from the umbilical vein to the right atrium. So on the left here is the desired position. You see the umbilical vein, and it comes up and then it sort of arcs over. And there's this structure here called the portal sinus or portal venous confluence, which is really it's a confluence of the right and left portal veins as they come in embryologically into a central vessel. The ductus venosus comes off of that vessel and comprises a portal venous cable, so a portal cable shunt, where blood from the umbilical vein can pass through the ductus venosus and into the systemic venous atrium. And you see the hepatic veins there. So when it goes right, it snakes its way through and makes its way to the heart. When it doesn't go right, it gets stuck in one of these channels. either the left or the right portal veins. And it kind of makes sense that that would happen. These channels are designed to drain blood this way. And into and then you're really you know, all these branching patterns come in towards the into the main portal vein in a way that, you know, when you're pushing the catheter in, it can easily feed this way into any of these channels along the way, kind of get stuck, and you're really needing it to snake into here. When this is a demonstration or an illustration of what it looks like when it's stuck down in the right portal vein. I want to point out the middle, just draw your attention again to the middle set of panels, because in this case, the catheter is stuck in a left-sided hepatic, a left-sided portal vein. But many of us see this radiograph, particularly if it's angulated a little bit, or if the catheter's made its way a little higher to say here, and say, well, it's just a little bit short, so I can use it for whatever you need to use it for. And that's sometimes not correct, and I've seen injury where someone assumes that this catheter is in the ductus venosus and just a little shallow, puts epi or TPN or something through it, and ends up with a liver complication as a result. So in addition to using ultrasound for real-time guidance during placement, there's a reason to use ultrasound to confirm placement of catheters after they've been placed, or if you get a patient where the catheter has been placed by somebody else, or whether potentially it's moved on radiograph, to confirm that it's actually where you want it to be. And there's a literature for that as well. Here's another representation of this anatomy, demonstrating that it's not as straightforward, literally speaking, as it looks by anteroposterior radiograph. This is a panel from Gray's Anatomy over 100 years ago. And it's not sort of a true AP view or a true lateral view. It's sort of an oblique view with the liver kind of splayed out to the side. And I just like it because it demonstrates the sort of circuitous path that the ductus venosus has to take. The umbilical venous catheter has to take to get to the ductus venosus. So here's the umbilicus over here, and the umbilical vein goes up the anterior abdominal wall in the midline. And then, excuse me, it has to take this sharp curve. It dives deep, and it has to then dive deep and then make another left turn, or turn northward to head cephalad up into the heart. So it's really an S turn, and you'll see what I'm talking about when we look at the ultrasound. Along the way, it can get stuck here, it can get stuck here, here, or it can overshoot the ductus venosus and end up in the right portal vein. So this is sort of a lateral view of what this anatomy looks like. You got to get it to really do this S turn to get to where you want it to go. I think somebody on the line was somebody on the line trying to ask a question? Sorry.
I think it's cool. I'll maybe just chatter.
Okay. So this is another way to look at this. These are angiograms taken in the cath lab, contrast injected in a low-lying umbilical venous catheter that's sitting sort of just south of the or just distal to the entrance of the portal sinus. This is an AP film or an AP projection. This is a lateral projection. And in the lateral projection, you can really see, kind of like we're looking at in the last slide, what this course looks like. This catheter's got to come up here. It's got to not get stuck in any of these channels, and instead make its way to this little guy and get up to the right atrium. I like this just because it's image rendering is, 3D image rendering and volume rendering is fun. I mean, I think all of us like it, medical imaging. This is a cardiac MRI, a contrast ferromoxetol enhanced cardiac MRI, which has been volume rendered to show the relevant anatomy. And I'm not going to play through the whole thing because it's kind of long, but I'll scrub through it and show you some bits of anatomy that I think are interesting. So as it turns from AP view to a lateral view, you see the heart, the superior vena, inferior vena cava. And then as we cut in to the anatomy, you see this is sort of the equivalent of a bicaval view, right? You see the aortic arch here. This is one of the large hepatic veins coming in to dump into the floor of the right atrium. And as it plays through a little bit more, you're going to see coming into view here, the ductus venosus there. So you can kind of, so here's the portal venous system down here. Here's the subdiaphragmatic vestibule, or basically the confluence of the right atrium, the ductus venosus, and the hepatic veins. And this little guy is the ductus venosus. You can kind of see it. You saw it sort of go by there. So that's where you got to get your line to go. Then the rest is portal venous anatomy. Filling that back out and then sort of shell filling it, which is what I'm doing now, getting rid of the rest. You see, take another look at that anatomy. Sorry, let me just go to the end here and where it goes. Okay. So there's that chance. So there's zoomed out the IVC here, hepatic veins here, and here's this channel right here, which I'll zoom in on. That's where you need the catheter to go, right? This guy right in here. And we've actually used this this volume rendering to create a gel model, which is pretty far along in the process of being turned into an ultrasound trainer. So as soon as that's available, I'll be happy to share it with you guys. So here's how you do this. The restraint technique is courtesy of Andrew Castorino. I don't know if you guys know him, but he's our CSU division chief at CHOP, and is sort of a jack of all trades. Was a PICU doc and a NICU, a neonatologist for a long time, in addition to being an anesthesiologist before making his way into the cardiology world. So he's taught me a lot about placing umbilical, arterial, and venous catheters. And this sort of diaper papoose restraint is his creation, but it really works amazingly well. The babies chill out. They kind of like the gentle restraint, and they let you do what you need to do on the belly button without getting in the way. So this is a pair of diapers connected in series, wrapped around the legs, and a piece of elastic tape over the knees, and connected to the bed. I find a bump under the hip does a lot to help the positioning of the hips, and it can help the catheter go where you need it to go. And then this is sort of a reverse swaddle, kind of laying on the beach pose to keep the arms out of the way. The two types of probes are helpful here. I'm vendor agnostic. These are just stock images. The larger format linear probe I find really helpful for its excellent spatial and temporal resolution, and for catheter guidance. I think that's an anatomic definition. That's definitely the way to go. Early in the procedure, which I'll talk about in a second, you really want to make sure that the ductus venosus is patent. The cardiac probes, the phased array probes, do a much better job at high frame rate imaging and color Doppler imaging. And so I often use this to confirm color flow within the vessel of interest before we start, just to make sure that it's patent. Now, obviously, it depends on the size of your baby. I have colleagues who do this in super premature babies, and this probe will go stem to stern. So in those kids, they'll use a smaller format linear probe or a smaller format cardiac probe. So you take the probe, you place it in the midline, oriented sagittally, sort of subxiphoid. The nice thing about the larger format linear transducer is it takes up a fair amount of real estate, so it gives you a nice wide field of view, and you can see most of the way from the umbilicus, or the umbilical vein, to the heart, or the bottom of the right atrium in the subxiphoid area. So of course, as for preemie, like I said, you might want a smaller transducer. So if you think about the orientation of the vascular anatomy, the umbilicus is midline, and the IVC and right atrium are slightly right of midline. So the imaging plane that captures most of the important structures is essentially sagittal, but rotated slightly counterclockwise. And then often sliding a bit to the patient's left and tilting the beam back slightly towards the patient's right brings the relevant anatomy into view. Sometimes, depending on the kid and their vascular anatomy, it's the opposite, sliding a bit to the right and angling and tilting back to the patient's left. And I encourage you, as you're trying to get started with this, to just practice imaging umbilical venous catheters that are already in situ around your unit, because then you get a sense for the muscle memory, and it's easier to get the views you want when you're trying to do this procedure with ultrasound guidance. So I think really just take a few minutes with each patient to try to make small adjustments and get the window you want. Each kid's a little different. For orientation, this lateral radiograph corresponds to the sagittal plane of ultrasound imaging, and so you can see the relevant structures. The heart is obviously here, diaphragm here, endotracheal tube up here. Umbilicus is sort of top right. This is the UAC, which you can see in the descending aorta, just anterior to the spine. And then here's the umbilical venous catheter here, of course, making its way from the umbilicus down through the liver, and then up into through the diaphragm, or past the diaphragm, and up into the heart. So if you put the transducer here, you get an imaging window that looks sort of like this, and that's what your image will look like. That catheter is passing through the portal sinus, through the ductus venosus, and into the low right atrium, where the diaphragm, of course, is here, and this is one of your hepatic veins. You notice that you see the hepatic vein and the ductus venosus nicely here, whereas you don't see the IVC. In some views, you can see the IVC and ductus venosus, but it's kind of hard to see all three. It's you're off a little bit. You're a little bit more medial than the IVC, where the IVC comes in when you get this view. So, like I said before, you start instrumenting a patient's intravascular catheters. It's important to make sure that you're going to be able to do what it is you want to do. In this case, you want to make sure that the ductus venosus is patent.
I'll get it.
So so you want to make sure that the ductus venosus is patent. So there's two ways to do that. I use both of them frequently. One is color Doppler, and the other is agitated saline. So when you turn on color Doppler, you get a view that looks like this, where you get flow coming from the portal sinus into the ductus venosus, and you can, in many patients, connect it nicely. And as I mentioned, the phased array probe gives you less anatomic definition, but better color signal. You'll often see some bidirectional flow because there's reflux into the ductus venosus with cardiac contraction. You can also demonstrate ductus venosus patency with agitated saline injected into the low-lying UV, and that saline contrast allows you to really visualize the anatomy nicely and get sort of a roadmap of where you want your catheter to go. You can also see some of the hazards. Whereas a catheter coming here, you want it to go here, it might want to hang up here. Getting just to start to get a sense of what we'll be looking at. So this is how the setup looks once you get started. So the baby's head is off to the left of the screen. The baby's head is off to the left of the screen. The feet are obviously over here. In this view, which is oriented the same as the photo of the baby in the background. And what you're noticing here, so is I just want to point out a couple things. I find it way easier to drape a wide sterile field and put a sterile cover over the ultrasound probe so that you can do both imaging and catheter manipulation yourself. Some people like to do it with a second set of hands where they have a friend image non-sterilely under the drapes while they manipulate the catheter sterilely. I find that clunky. When you're doing it all yourself, your left hand knows what your right hand is doing, and vice versa, and so you can see what you're doing more easily and follow what you're doing. I think sort of more fluidly and make adjustments as needed along the way. So I basically drape the patient. So I prep the patient essentially from hips to nipples and from sort of anterior axillary line, from one anterior axillary line to the other, and make a wide sterile field and drape it with towels, make a little tent over the head so they can breathe, and so that the nurse can get in there with a pacifier and sweeties and whatnot, and then just set up the console so that what you're seeing on the screen matches what you're doing with your hands. If you're lefty, I like doing it this way because I'm righty. If you're lefty, you can feel free to use the other side of the baby and flip everything the other way. But I think this sort of setup works well. So this is these are some still frames of what the procedural imaging looks like. In the left panel here, you see the umbilical vein at the top with this catheter in it, marked by arrows. So the catheter is traversing the ductus venosus, the umbilical vein, and entering into the portal sinus, but the tip of it is getting stuck. If you follow it, the tip of it, you lose it a second, but the tip of the catheter is right here, stuck in the left portal vein. And you'd instead wanted it to go down here and then this way. In this right panel, the catheter has been advanced under ultrasound guidance past that problematic area up here, and instead down through the portal sinus, across the ductus venosus, and into the heart. So I'm going to show you how ultrasound assists in navigating that path through the portal sinus to the ductus venosus. So here you can see a number of left-sided portal veins. These are all of these are left-sided portal veins. This is the portal sinus. The right portal vein is down here. You can see the left. You can see the portal sinus and right portal vein, the portal sinus and ductus venosus, or some combinations of those in the left portal vein all at the same time. You can't really see the left portal veins, the right portal vein, and the ductus all in one view, just based on their arrangement. But if you remember from that Gray's Anatomy figure, if you continue on past, the ductus venosus comes off, here, and if you continue on past, the right portal vein continues to head sort of deep and rightward into the right lobes of the liver. So the catheter often likes to go someplace you don't want it to. It'll go there, it'll go too far and go there, it'll head this way, and really you want it to go that way. So I'm going to show you how with titrated liver pressure, you can adjust, you can really manipulate that anatomy to get to create a more favorable catheter path. So the main manipulations that are done while placing an umbilical venous catheter are liver pressure, right? Some positioning changes and line over line stuff, but push on the liver this way, push on the liver that way, and see if you can get it to go. And with ultrasound, you can see why that is the time-tested, strategy for trying to get difficult lines to into position. When you push with your ultrasound transducer a little, or when you push on the belly from anterior to posterior, a little bit of posteriorly directed compression, the anatomy changes. What happens is those left-sided portal veins that were ready to accept your catheter before get compressed. The orifice of the veins, the entrance to the veins, gets compressed, which makes it less likely that they're going to swallow your line. And then the takeoff into the right portal vein becomes more acute, as opposed to this nice curvy line like you see in the left. It becomes more of one of these, which makes it less likely for the catheter to go there. And it also makes this a straighter shot. So that's why liver pressure works in this process, but it works a heck of a lot better when you can see what you're doing. So I'm going to show you a few brief videos of the technique in action. In the first video, I'm going to show you the relevant anatomy and how to assess the patency of the ductus venosus with color Doppler and agitated saline. Eric, is that playing smoothly or is it choppy?
That looks pretty good in smoothness.
Okay, so there's the anatomy there. I was going to pause it for a sec, so as the labels are coming up. So this is you can tell from the sector here that this is a phased array probe. which is, as I mentioned, does a good job of color Doppler and assessing ductus venosus patency. So what you see as it pauses, I'll put some labels on there. So there's the umbilical vein at top, there's the catheter, there's left portal vein, portal sinus, and ductus venosus with the right atrium at bottom left, and then the aorta at the bottom. So when you turn on color, you see flow going from the portal sinus into the right atrium. If you inject agitated saline in your low UV, you can see it coming into the heart, and also identify the entrance to the ductus venosus in case it wasn't obvious by 2D imaging alone. This is another patient with the same procedure in a different patient. So in this next video, we're going to talk about, we're going to review the most common reasons for malposition. So you'll see the umbilical venous catheter caught in the left and then in the right portal vein. So here's that image that we talked about at the beginning where the catheter caught in the left portal vein. Here's what it looks like by ultrasound, with the left portal catheter coming in at the top marked in blue and the left portal vein over there in pink. And when the image starts moving, you'll be able to see it nicely. So see how it bends over there and gets stuck in the liver where the arrow is, and you want it to dive down. So now we're going to look at what the ultrasound looks like when the catheter is caught in the right portal vein. And there, it's down through the ductus, the portal sinus all the way, and into the portal vein that's partially off the screen. I am highlighting it there so you can see it better, but there's the catheter. It's overshot all of the structures you want it to target. And then there it is, deep. You can probably see it here. Here's the catheter deep in the right portal vein. So to get this image, I went way off to the right, image over the right side of the liver, and that's where that catheter has landed. So there's the right portal vein. And there's the umbilical venous catheter, and there's the UAC in the aorta at the bottom. So for this, in this third video, I'm going to show you how that titrated liver pressure works. So you basically accomplish that using your imaging hand with the ultrasound transducer. And so instead of just pushing on the liver with your hand, you push on the liver with your hand and the transducer while imaging at the same time. And it's a little awkward at first, but really you get the hang of it pretty quickly. And I'll show you how that technique manipulates the anatomy in such a way that the catheter has a more favorable path to the heart. As with any ultrasound-guided procedure, it's really important to keep track of the location of the catheter tip. It's very easy to be sort of looking at the middle of the catheter and the end of the catheter is off doing something else, particularly when the vascular anatomy gets more complex like this, as opposed to a more straight tubular structure, when as in the case of arc lines or central lines. So here you see how the anatomy changes when you push a little bit on the liver. Do you see how the catheter, or how things are flattening out there? There it is in its native configuration, and then there it is with a little bit of posteriorly directed liver pressure. Again, before the catheter can go there, you want it to go there before manipulation. And with a little bit of titrated liver pressure, abdominal compression with the ultrasound probe, you flatten things out. The portal veins are less likely to accept the catheter, and that you have a flatter angle for your UVC to get into and across the ductus venosus. And then there it goes, which is really satisfying when it works. And it works a lot of the time. And that's another patient. You can see it sort of sliding in right there into the bottom of the right atrium. And then you can use that to site it and position it. Here it was in a little deep, and so we retracted it a bit. And some here the before and after radiographs. So a little deep, as I mentioned, so we retracted it back a little bit and left it alone. Okay, so in this last fourth video, I'm gonna show you how line over line technique or why line over line technique works and how you can augment that further using ultrasound. I think a lot of people who are neonatologists or have placed UVs in the past know that there's a technique where if you can't get your line to go after multiple attempts, you just leave it, you put it until it gets stuck, and you leave it there, and then you follow it with a second catheter. And the idea is that the first catheter goes into whatever sand trap you don't want your catheter to go into, and you leave it there, and it blocks that up, so that the second catheter hopefully can't follow it into that same undesirable location, or is less likely to do that, and instead passes into the desired location in the ductus venosus. So with ultrasound, you can actually see how this works and see whether it's working. So, sorry, that I need to play that video. So here's a patient with a low-lying UVC after an unsuccessful attempt. And what you see by ultrasound is that this catheter is coming in and getting stuck in a left-sided portal vein. And if I pause it, like, it's really a massive left-sided portal vein. And so if you think about it, this catheter, which is a 5 French catheter, which relatively stiff, you want it to go down here. And there's no way it's going to do that. It wants to take the straightest possible shot, which is going to go from here right into there. And it's going to be really hard for it to go somewhere else unless you start using some pretty fancy tricks. So what we did was just left it there, and you'll see the second catheter, which in this case was a 3.5 French catheter, start to kind of come in and blink up in here, and that catheter will navigate that catheter past this hazard and into the desired position in the ductus venosus. All right, so that first catheter occupies that, and now see the second catheter coming in. That first catheter occupies that hole, whereas the second catheter slides right by it and gets into the ductus venosus. So that's how line over line technique works. We deliberately left both, so then you leave both catheters in. We deliberately left them in deep. I know that the radiograph is a little bit comical, but we deliberately left with one catheter probably in the left atrium and one catheter way off in the liver. We did that on purpose because we left them deep on purpose because we knew that when we tried to retract one catheter, we might drag out the hard won properly positioned line as well. And so we left them deliberately deep at first, separated them on the belly to be just absolutely sure we knew which one was which, and then pulled out the first one, which did drag the first one, the second one back a little bit, and then reposition the second one to where we wanted it in the low RA. You can focus the talks, it's designed to be focused mostly on UVs, but you can also use ultrasound to assess umbilical arterial catheter position. This is that radiograph lateral radiograph we looked at earlier. Like the UVC is there, and then the UAC is right here anterior to the spine. And so that's this is what that looks like by ultrasound. So here you can see the UV right here, and then the UA right down here. And this is relevant because we want the UAs to be above the diaphragm. There's a mnemonic for it based on T6 to T6 to T9, but every patient's a little different in their anatomy. You want it to be above the diaphragm. You want it to not be so high that it's up in the aortic arch. I admitted a kid the other day with a UAC across the ductus arteriosus and in the pulmonary artery. That's suboptimal. and you want it to avoid the mesenteric vessels where a thrombosis, a catheter-associated thrombosis, could compromise the viscera. So really above the diaphragm, above the mesenteric vessels, kind of behind the heart, not in the arch. And you can really figure that out and reposition the line in real time using ultrasound if you know how to look for it. So again, here it is there. All of this ultrasound shadowing is a problem though, and I'll show you how to avoid that. That's air in the posterior lung, and as you all know as well as I do, air and ultrasound are not always the best of friends, so it can make visualizing the tip of the catheter pretty challenging. Here it is by radiograph. In this short video clip, you can see the catheter here. This is a sagittal view. This is basically a straight sagittal and left parasternal. So not left parasternal with the angulated off to the shoulder, but instead parasternal straight up and down, lined up with the descending aorta. So you can see the heart, you see the diaphragm over here, the liver, and then the catheter bouncing. But that right here, that air artifact really obscures the tip of the catheter. Sometimes it's right in there and you think you see it. Sometimes it's beyond. And if you know what to look for, and I'll play it one more time, you can see that the tip of the catheter is actually kind of over here. See it bouncing over there? You just have to do it a bunch and get used to it a little bit, but there's also ways to bring it out more clearly and different views that you can take. So this is one such view. So this is a subcostal view with the phased array probe, angled cephalad. You can also go high parasternal and angle caudal, and that allows you to get out from behind, sometimes at least get out from behind that air, and you can see the catheter there bouncing in the aorta. This one was placed a little too high. You can see the tip of it all the way up here. Probably, I guess that's not clear. So see it right. You think you see it right there. It's actually a little further up, kind of right here. Okay. You can see it in the orthogonal view as well. So here's the descending aorta here. And there's the catheter. So you can kind of sweep up and down the chest until you see it. And if you know how to associate it, your desired position with the cardiac structures, namely roughly at the level of the left atrium, you can position it accordingly, or at least confirm that its position is where you want. Going back to the umbilical venous lines for a second, we just put some numbers on the technique that I've been describing. We published about a year and a half ago the results of our first 32 patients. It was a 3-center study, CHOP, Mount Sinai, and Stanford. Courtney Giuliano, who's the medical director of the NICU at Mount Sinai, was the person leading that effort there, and then Shazia Bombal at Stanford, and many of you know my colleague at CHOP, Maki Fraga, who is one of our neonatal ultrasound lead. Anyway, we decided to focus on babies with congenital heart disease. For uniformity, really, and most of the patients, because I was sort of pushing this, most of the patients ended up having congenital heart disease. So, but 3 centers, 32 patients, mean gestational age 38 weeks, and with a mean weight of 3 kilos. Although the smallest kid in that study was 1.2 kilos, and we've some of my collaborators on that on this project have subsequently done them down into the 800 or 900 gram range. The median age at the time of UVC placement was 16 hours. 24 of 32 patients, so 3/4 of patients, were on prostaglandin at the time of ultrasound-guided UVC placement, and that's probably relevant because there's data from the developmental literature, like fetal lamb circulatory studies from the 70s that and 80s that the ductus venosus is probably prostaglandin sensitive, as is the ductus arteriosus. We all know that, like the ductus arteriosus, it involutes over time. And so the earlier you get to it, the better your chances of success. So let me back up and say that just to be clear, that this study was a study of looking at whether we could rescue malpositioned lines. So rather than use it, I use this now for primary placement all the time, but we were looking at patients who got born in our delivery room, had a UVC attempt by the traditional method that was unsuccessful. And then we decided to see whether we could use ultrasound to get that failed line, to convert that from a failed attempt to a successful one, to get the catheter to its desired central position. So in some ways, these were the patients enrolled had already been identified as difficult UVCs, which I think is an important distinction. Of those 32 patients with failed UVCs, we were able to rescue them and get them central roughly 3/4 of the time. If we got to them in the first 48 hours of life, we rescued 80 of them. After 48 hours of life, the success rate was substantially less. That math on the bottom is there to illustrate something that I think is really was an interesting finding here, and that was that the rate of, if you take a 2/3 success rate, and then you just in general with the traditional technique, and then you rescue 75% of the lines that were unsuccessful, then you bring your overall success rate up to in the range of 90 to 95%. And what was interesting to me about that is that those are almost exactly the same numbers that we saw when we made ultrasound the standard of care for percutaneous central lines and percutaneous art lines in pediatrics. So anyway, so that was exciting to us, and we've continued to do this. We've done a bunch of patients. I did 3 or so in the last couple of weeks with both myself and then with people who are relative novices, and the learning curve is not that hard. So I mean, sometimes they're frustrating, sometimes they take a while, sometimes they're quick and super satisfying. But it's a procedure that has gained traction in our unit, and I think others in the neonatal world and CICU world are starting to employ as well. So I'll conclude there. Thank you very much. These are my kids. That's my daughter helping with our CHOP ultrasound course there in the middle. The procedural videos are up on YouTube, and that QR code will take you there if you want to check them out again at any point. And I'm happy to take any questions, and happy to talk at any future date if you or your group is interested in learning a little bit more about this. Thanks so much.